Thank you so much for joining us for today's Health Professions Educator session. We welcome you to add your comments and your questions in the chat function throughout the presentation. You'll also notice that we may have already added, Deb usually does this, to the CME link in the chat for you. Presenting for us today, we have Dr. Arthur Ollendorff, who is the designated institutional official at Carilion Clinic. He is also the Associate Dean for Graduate Medical Education and a professor with both the Department of Health Systems and Implementation Science, as well as the Department of Obstetrics and Gynecology with the Virginia Tech Carilion School of Medicine. I'll now turn our time over to you, Dr. Ollendorff.
Right. Thanks, Sarah, and welcome everybody, and welcome from the Westin in Richmond, where I currently am at our perinatal quality collaborative meeting. I was supposed to be giving a talk at the same exact time, but we were able to switch it around for us. But I'm going to go do the most difficult thing, I hope, of this is switching over to so you can see slides. And the slides are really there more to kind of keep us on, kind of be like a level setting here. So let's make sure this works okay. Really what I want to talk today is about the UME to GME transition and how do we improve the process. And, yes, you could argue that it's a very timely talk because match day was Friday. I would argue that while some people would say this is the beginning of the transition, I would argue the transition happens the first day they come into our schools. And hopefully during the course of the time, or hopefully it's not going to take the whole time, we'll have lots of time for discussion and learning what people think of what's going on. We'll know a little bit more about that. So you already know who I am. So I don't have any financial disclosures. I wish I did. I am the current president of the Association of Professors of Gynecology and Obstetrics, or APGO, and a lot of this work is grant work that's actually grant funded to APGO that I'm part of. So that's a bit of a disclosure. I'm also the co-chair of the VNPC, but that has nothing to do with this talk per se, although I will talk about maternity deserts because I can't not talk about those in my role as an obstetrician. And obviously with any kind of talk, I'm biased by my experiences and things that I have seen, and I will try to minimize that bias as best I can. There's definitely some science here. I'll share the science, and when it's a personal opinion, I will tell you it's a personal opinion. And the truth is probably somewhere in between. So if there are three things we can get out of this, and I think two, some of them are probably already clear to many of you. One is to acknowledge why the UME to GME transition is important. And it's just good to go over the basics. Sometimes it's obvious on some levels, but a little bit tricky in others. And I'm going to talk a little bit about what a lot about OBGYN, just because I'm more hip deep in that, but what some other specialists are trying to do to ease that transition. Then hopefully, in your role and what you do, if you can identify one thing you can do to help that transition for our medical students or other medical students you work for, that'd be awesome. That might be my aspirational goal of this session. And there are a lot of opportunities, no doubt. So this is a slide that I saw when I gave a similar talk at our APGO annual meeting, just remembering the journey to becoming a physician. And it's a long journey. And, I've been thinking about this a little bit. It's my 30th med school reunion coming in October. It was my anniversary, my 30th match on Friday. I matched on St. Patrick's Day in 1993. And this makes you realize, college to med school, then, you go to residency, maybe you go to fellowship, and maybe you go into practice and back into fellowship. There are a lot of different pathways that people can take. And this road to becoming a physician is actually not unlike a road for me as a perinatal substance use person. The road is not always straight. There are bumps, there are blips, there are changes. I'm still always amazed that 96% of residents pick the right specialty, pick the right place, and they finish in the program that they start. So we actually, in some ways, we do a really good job of having people find where they want to be. And most people are happy where they are. But I think it's always good to reflect that this is, there are definitely break points. And, the transitioning to residency is another break point in this kind of journey to becoming a practicing physician. And the other issue is the GME to UME transition is actually really important to me because one, it's a clearly identifiable landmark, right? You're entering a specialty, you're typically leaving where you train. So there's actually a change in place as well as a change of focus. Most people choose their medical specialties in that time, although some don't. Some people do transitional years and prelim years and trying to figure it out. But I think for me, as someone who does a lot of work in perinatal quality, and as I look at what our role is as educators, where you go and the type of residency program you pick really influences where you practice. And I think that's why, I'll show you an article right now at Eric Humbo and Andy Bazemore, people that I've worked with before, they talk about the social contract of medical education, and it's a real thing. Why is it a social contract? Number one is a lot of money spent on it, so CMS and Medicare spent over $11 billion in GME in 2019. I also think, medicine is a vocation. I think it's a calling. I think it's very difficult. And I think we're struggling with that right now. My conversations as a DIO right now are really involving how do we take graduate medical education from a transactional role during COVID? You're covering this shift. We have these needs back to the more of that, educational and having those interactions with learners. And I think the other thing is really important is one part of it being a profession is being allowed to self-monitor. And I always rather have physicians monitor themselves than have someone else do it for us. It's how I kind of felt with duty hours. I much rather have had the ACGME come up with duty hours than have a federal law and having Special Agent Jones coming to say, hey, so-and-so has gone over their duty hours like they did in New York back in the day when they had duty hours. It was enforced by state police. And that's probably not the way we want to do things. So I think if we can really be on front of it and really live to our professional standards of self-monitoring and realizing, who knows best what to do, I think physicians, but also informed by the public and informed by other people. So there are 3 questions about the UME GME transition that I have, and I don't say I have answers to it, although I'm developing answers over time, and maybe we can answer them together or have more questions together. But the first question I have is, are graduating medical students prepared for their roles of residents? And if not, why not? We've had 4 years. They come to medical school, 99% of our medical students go into residency. We shouldn't be surprised they're doing residency. What can we be doing better? Are there things that we can be doing curricularly? Are there other things that we can be doing? Also, what are the effect do our curricula have on choice of specialty and practice location? I mean, not so confidentially, the APGO world, we're really talking about where's our focus as we have the impact on medical students, and 95% of which don't go into OBGYN. So what are we doing earlier in the pre-clerkship years, the preclinical phase, whatever you choose to call it, that really will help us understand what people know, not just about OBGYN, but any specialty. If you lug, I was really excited to see someone at Matchday going into PM&R. And I kind of wanted to ask them, how'd you learn about PM&R? When did you get that opportunity? It's a great specialty. But, where was that exposure, and how did that person get that, that bug and decide to pursue it? And then how we are advising our students. Are we actually advising them in a way that meets their long-term goals and the needs of our communities? And that's a big, broad, lofty discussion, but I think it's a really important one as we really look at the really key way we affect workforce and the way care is delivered. So I'll just talk about location. And we know location is a big part of it. The data has been very clear how location really affects practice location. But when you really dig in that data, it's really, really interesting. So Michigan is an example. If you do your residency in Michigan, your likelihood ratio is 5.3 that you will stay there after you're done. So, if I'm a legislator, I'm like, so if I get people to stay in Michigan to train, they're likely going to be here as a physician. Well, not surprising. They chose to be in Michigan, probably because they liked it. Then they made their connections in Michigan or fill in any other state. This is pretty reproducible. It's true in South Carolina, like you can see. But it's also true for disciplines. So in family medicine, they know that, if you train in family medicine in a given state, you tend to stay in that state almost 3/4 of the time. So it is a really big driver. So where you train really does matter. It's what you're exposed to, and it's what you do. And that really has pathway effects. So where does your practice setting matter? Well, rural primary care is something that's been looked at for lots of people. If you went to a rural high school, not surprisingly, you are probably 4.5 times more likely to practice in that rural area. And if you go, and you're 8.5 more times likely if you train in primary care. People that have done pathway programs, be it for, underrepresented in medicine or rural or urban, we recognize that recruiting and supporting those who are going through that process is critically important, and you're going to lose people along the way. People like, I want to be, my wife had a decision to do primary care or do PM&R. It's actually what she wanted to do. Well, she was in the military. The military says, no, we don't need PM&R. You're doing family medicine. And she loved it. And it was great. Not everyone has that sort of decision forced upon them, but people make different decisions. I was going to be a neurologist when I went to med school. I am clearly not a neurologist. I'm an obstetrician. But also how you train them, where they go, where they spend time. And this all comes a lot from Randy Longnecker, who did all his work at Ohio University, now actually lives in the region. And I think we're going to talk to him about his experience in rural training and how to get people and what curricular elements can you have that really gets people to go into rural practice or primary care, and they can live together. And I think Mayhec's a great example. That was my previous job. I was the DIO at Mayhec before coming here. And then in the class of 2020, we had 26 graduating residents between family medicine, OB, dental, and a couple of fellowships. 12 of those 26 went into rural practice and 10 into HIPSA regions. But at the same time, we had 3 people going to fellowship. One went to MFM and 2 went to addiction medicine. So once again, it's not either or. You can do both. You can have a rural mission as well as having people who want to do fellowship and work in urban areas. It's just how you develop your curriculum. And Nashville is a bit easy because that was our goal at a state-funded AHEC. And we also were able to recruit people who wanted to do that. There are definitely ways of doing it because I've seen it, and it's real, it exists. So as an OB leader, putting on my APCO hat on, so if where you train, especially in residency, is really important in location, well, here's a problem we have in OB. There's a big swath of the country that has no OBGYN training programs. There's not an OBGYN residency in Idaho, Montana, South Dakota, North Dakota, or Wyoming. So they're going to have a different tactic of trying to retain and recruit as compared to other parts. But not surprisingly, these are places that have very low numbers of OBGYNs. And it's a chicken and the egg phenomenon. There are a lot of things that go into that, especially post-Dobbs. But once again, it's where we're training. And, this is a place where the WAMI program is working in the medical student side. If you don't know, the University of Washington's WAMI program, where they selectively take people from Montana, Idaho, and other places to help build up that workforce and get people into medicine. But when you don't have residency training programs, it makes it really hard, especially in OB. They have residencies in other disciplines, but they're much smaller in number than other states. So for me as an OBGYN, this really relates, and I'm sitting at our perinatal quality meeting. It's about maternity care deserts. In OB, if we don't train people in regions of care, they're not going to be doctors to take care of them. And there are some, you can look at, it's hard to see this map because it's all together, but there's a lot of red in the state of Virginia, especially in our part of the state of Virginia. And some of these maps look not inconsistent to the map I showed you before of where they're training. So once again, in OB, it's very clear that, we have deserts, we have pockets, and training programs might be able to help that. If we have the right training, it can either be a medical school too, but residency would be another great way of doing it, being a rural track or another way of doing it. So a little bit of break before we go to the next section. I just found this really funny because I've worn my white coat 3 times. I was never a big white coat wearer because they tend to get dirty, especially in OBGYN world. But yeah, this is the journey of your white coat as you go through training. And I know right now we have a lot of 4th-year students who are probably donating their white coats, and good for them because they're going to the next stage. They get the longer white coat, which is definitely an honor, but part of that UME GME transition, no doubt. So here are a couple of sort of provocative questions about what I think are the problems of the UME to GME transition. And some of it's, like I said, data supported. Sometimes it's actually not particularly data supported. So number 1 is the application process dominates the bulk of the clinical phase of medical school. And if you were in any part of the conversation we were having at BTC SOM about how can we maybe compress and have a 3-year medical school program, we realized, part of it is, they have to have a guaranteed spot for residency. That gives you about 3 months just off the bat. And there's no doubt, there's the time and effort, the cost, and the stress. The stress release that we saw on Friday is evident of the stress of the process. And, I worked with one student this year who's a friend of my daughter's who didn't match an OB. She's at another medical school. The stress of her trying to figure out, I still want to be an OBGYN. How am I going to do that? And hopefully we'll find a path for her. But the process alone, not only is it stressful, it always been that way. It's also just kind of crazy. And I'll show you some data in a second. The other thing is applicants and programs and leaders, I would say, place a lot of value how high or how low you go on your rank list. And, it's sort of a weird metric because I know when I applied, I didn't apply to that many programs. If I got any of the programs, I was going to be pretty happy at them. And if I got my top 1 or 2 or 3, yeah, you're always happy when you get your top choice. But what's your difference between your 3rd program and your 7th program? I'd argue very little. So we stressed out a lot about, where the best program is when there's lots of great programs for you. Are you looking at them? Are you finding them? Do you know where they are? And I know programs, having been a previous program director, the distinctions we make about students and what we call highly qualified are subtle at best. And I challenge any program director, and I do that to the program directors at Carilion, go back to rank lists of years past and see how they wound up. And sometimes your top ranked people were not your best people, and sometimes the lower ranked people were, because once again, we're trying to predict quality based on really odd metrics. And I think we're also probably as good as NFL quarterback picking. People that are highly drafted in the NFL don't become the best quarterback. And then you get the Tom Brady, who was the 7th, round draft pick, and, he turned out okay. And then the other thing that's really concerning is that with the vast majority of our students going into residency, when you ask them, when we've asked OBGYN incoming residents, do you feel unprepared when they start residency? And 1/3 say yes. So it's 1 out of every 3 across, it's not a VTC issue. This is every medical school issue. Why do 1/3 of our residents don't feel prepared as they should when we have the opportunity to do so? Where can we do better? Because it's already stressful enough having that greater independence. How do we mitigate that? Maybe never eliminate it, but maybe mitigate it. So these are things that OB and other disciplines are trying to look at. If you're not familiar with Simon Sinek's Golden Circle, we actually talked about it today at VNPC. One of my colleagues brought it up. It's actually one of my favorite things to talk about. It really talks about success, both as organizations and as leaders. And organizations and leaders that can talk about the why are very much more successful than those who talk about how and what, right? And if you talk about, the famous example that Simon uses is, you work at McDonald's, you talk to someone who works in McDonald's, like, what do you do? How do you do it? I take the fries, I put them in the oven, I put them in the oil. Why do you do it? They can't give you a compelling why. You talk to someone at Apple, they can tell you how and what they do. They can also tell you why they do it. And their why is probably they want to create amazing product that you don't even know you need yet. Like they have a true vision. Education is very easy for me. I know what I do every day. I help train future physicians and future workforce. That's really important to me. And I do that because, who's going to take care of me, who's going to take care of my daughter as an OBGYN. That's really important to me. So knowing the why is really, really important as we move forward. And I think, the conversation we have in the OBGYN world is, what's the why? Well, the why is the program, but I think the why is actually the student and the applicant. The programs will always get good people. It's the student that gets through this once, maybe twice. So as we look at this whole UME GME transition, I really would, yes, the programs are important. I'm a DIO. I think about programs all the time, but I really think about the individuals and how they're going through the process and how well we can make something that's very difficult, make it a smidge easier. So here's some data, and I wish I had the most updated data for you, but this is from Maya Hamoud, one of my colleagues who does a lot of work on this. And this was looking at, this is OB applications and looking at the number of applications per applicant. And it's ridiculous. The average OB applicant applying to 87 programs, kind of crazy. Does that help any of us do our work? Probably not. Is this multifactorial? Absolutely so. And you can see the growth in the change by, if you're an osteopathic graduate or if not. So it's 82 for osteopathic graduates, 67 for USMD graduates, and overall it's 72. You can look at psychiatry, that number is 80 for all comers. So the average applicant to a psychiatry residence applying to 80 programs, which is a lot, unsustainable. And there are lots of people that are looking at different ways of doing it, and we'll talk about some of those. This is the rate of available PGY1 positions per applicant in the main match, and this is looking at US seniors versus all active applicants. So if you are a US senior, it runs around 1.5. If you're another applicant, the chance of getting a space is a lot lower. So where you go to school matters. And right now, if you listen to Tom Naska, who's the head of the ACGME, speak, the largest single growth in people entering residency programs are osteopathic graduates, right? So that's going to put pressure on the quote marketplace as we've increased medical schools, both in numbers and in size of classes, but have not changed residency programs. But for OB, it has an effect. And then OBGYN, another way of looking at it, I don't have the number for 2023 yet, is the match rate or the unmatched rate. And the unmatched of people who applied as a US MD applicant, 16% of those who applied did not match into OB. It's 33% if you're an osteopathic graduate. It's 64% if you're an international medical graduate. That was in 21, and in 2022, you can see a similar stage. So there are people who want to enter the field of OBGYN, for example, and it's true for orthopedic surgery or neurologic surgery or any other competitive field, who are unable to match in their chosen specialty. And that's difficult to tell somebody who wants to be a certain specialty, and because of the way things work, it doesn't. Once again, this drives the culture. If I want to be an OBGYN and if I'm a US medical graduate, I know that 19% of the time I may not match. I'm going to apply to a lot of programs, because to me, that is how I increase my odds. And then this is the metric that gets shown all the time. And I would argue this is not a very meaningful metric, but this is out of a recent New England Journal article. How people, how often are they getting their first choice program or their fourth choice or lower programs? Once again, I think again, to any program you're happy with, that's a good thing. But this is something that definitely drives market, and I have, as a DIO, I've been told by a lot of my program directors, I got people in my top 10. I'm like, okay, tell me about number 10. Tell me about that person. Or I went down to 112 on my rank list. Okay, tell me about that 112th person. They may be a great person. Who cares? It's a metric that I don't understand. You fill your program with good people. That's what you really want to do. But we get very caught up in, to get my top 3 or, I get 4 through 7. I'm a little questioning if that's a really important metric or not. But people use it a lot. So I bring it up as an example, but not one that I really love. So I'm going to talk a lot about what OBGYN is trying to do to make the process better. And this is part of something called the RRR grant, Right Residency, Right Program Ready Day 1. So it's looking at both the application phase, but also how we are preparing them when their first day as a resident in OBGYN. And it is an AMA Innovations grant that's given to APCO and CREAG. CREAG is the residency arm of OBGYN world. There are a bunch of teams. I'm on the leadership team as the president of APCO. We have a learner advisory group that's huge. Everything we do in this grant, we run by our learner advisory group, because they're the ones informing us, because we're actually doing this all for them in the end. And we have different work group teams. I'm going to talk about those work group teams, and their names are changing. So I'm going to give you their old names. They may look different next month as we're changing some names. Incredibly data-driven group, publishing a ton, 33 publications since 2019. We're about halfway done with this project. And I think the thing I'm most excited about, and I am an implementation person, by nature, we're already talking about what has to transition from innovation to practice. There are things that we have studied, we know work. It needs to leave the grant world, which is innovation, and go into the normal day-to-day activities, which is the practice world. And we're talking about that even before the grant's done. Like, we're transitioning things actively to our main organization to say, we know this works, let's make sure it can sustain, because the sustainability of this work is really important. And some of those will become more clear when I show you the data. So this is a more graphical representation. We're looking at our different groups. We have a standards group. We have something called the ARM, or the Application Review Metrics group, a group called ACI, the Alignment Check Index. And then we have this very large group called ERAP that used to be the Early Result Acceptance Program. We were kind of hoping to have an early match that sort of fell through with the NRMP. So now how program signaling falls into that. And there's another group that's really looking at the readiness side. So once people are going into OBGYN, how do we make sure that they are ready day 1? So we're talking about some curriculum and assessment, some learning communities, and a lot of coaching. A lot of it is developing coaching teams, both as a national cohort, a regional cohort, and also at a program level. Talk a little bit about that, because that's really going to really come to fruition the last couple of years of this grant program. So one is the standards, and I don't think OB is the first to do the standards, but I think OB is probably one of the first of the larger programs to do the standards. ENT and urology and some of the smaller residencies have always had this, but really we wanted to have a common calendar of events. We wanted to make sure that if we all talk about we're going to offer interviews on a certain date, yes, the residents are still nervous, but they know when to be nervous, and they're not nervous over a span of weeks, months, or days. They're nervous over a few days, and it gets better. We were hoping it was going to limit the competition for releasing interview dates earlier, because a lot of this is, how do you review an application in a holistic way, but also offer interviews in a way that's fair? And what we found, we've done this for 4 years now in OBGYN, that developing standards that over 90% of programs voluntarily partake in has had high satisfaction among residency programs and incredibly high satisfaction among the applicants. Yes, it's still nerve-wracking. It's still imperfect. Some people still hoard interviews, but it happens at a much lower rate from what we can tell from the data sources that we have. And I think everyone just feels better about it. So this is something we realize that has to go into, this is no longer innovation. Like other people, other programs have copied us. Other disciplines have copied OB and done this. And this is going to start becoming a regular thing that's probably going to live in the world of CREOG, which is our program director world. They're going to set the standards and they're going to get people to continue, using them. And we're going to widely advertise them to our applicants and to our clerkship directors and our deans so they know what's going on. But we realize this is like a really good thing that was lowish hanging fruit. But it takes a lot of working together in leadership amongst the discipline, or especially to get this done. So we're able to do that. We're super excited about it. And it's going to continue. And once again, we'll probably leave the grant world and go into the CREOG world, which is our day-to-day, normal residency application mode. We have another group, and I'm part of this group called ARM, the Alternative Review Metrics, and we're really looking at holistic review and how do we identify what are the things that are necessary to do a holistic review. Once again, we were incredibly lucky to have step 1 scores go away because that really pushed this a lot, like how are we really going to evaluate applicants. So we came up and we have a paper that came out about this is like, what are the models? What can we be looking at? What attributes are we really looking for? What experiences are we looking for? And then how do they align with what applicants are looking for and what programs desire? So a lot of us is naming it. It was a work group of about 85 program directors and learners that really help us put this together. And we came up with some, not surprising type of things, location matters. What type of training did they get? Especially we talk a lot about abortion training or global health. Are you in a state where you can actually do an abortion and actually experience that or experience counseling, or you can have to go somewhere else? Practice setting is actually a big deal. Like we talked about, where you wind up doing residency, we can dictate what type of practice setting. Some of these are obvious. You want to be in a rural area, you may want to go to a place where they can train you for rural, or there's experience in sending people to rural. What are the issues around equity, diversity, and inclusion? Distance traveled, we talk a lot about that. Is that something that program directors really value? But how do we get that into an application? How do we really have a great way of displaying these characteristics we really want? And professional goals. So this was the beginning of a discussion about like, these are important things. How do we get them into an application? How do we do holistic review? And how do we have applicants and programs share that information in a way that we can really match people up in the application side, not so much in the final match side. The other thing that came out of this group is coming up with a standardized letter of evaluation, or the SLO. We call it the SLO, not the SLOE. It's slow like slow gin. That's how you can remember that. So, COPA, the Coalition for Provision Accountability, talked about having structured evaluations as being really important. We thought it could be really helpful in mitigating some of the inequities that we see in the evaluation process. It really supports holistic review if you do it correctly. And once again, OB is not first to this one. Emergency medicine's been doing this since 1997. They've gone through many iterations. They now have an electronic SLO. They call it the eSLO, or the eSLOE if you want to call it that, but they call it the eSLO. And all their letters are that way. In OB, we started ours in 2021. We've modified it a couple of times along the way. And right now, one is suggested for each applicant. And I think for next application cycle, for the 2024 cycle, we're going to say one is required, although we have no way to enforce that. But we've had such good uptake of our SLO. And we keep kind of tweaking it based on feedback. It's becoming a really helpful one. And realizing this is just one of your 3 other letters. You'll have traditional letters, but I would, if you look at traditional letters, what we've just, we've had a lot of great conversations about SLO with NRMP people, with, I'm representing this at Live, Serve, Lead later on next year. And what we realized is standard letters of evaluation really talk about the letter writer more than the applicant, if you read letters enough. And it's how well they write the letter, not actually the true attributes of the applicant. So the SLO helps with that. So we ask some information about the writer. We want to know where they're from and what experience they've had with the applicant. And we made it criteria based. We don't want to say they're in the top 10%, top 10% of what, right? Top to 10% of legal airman's experience of teaching for 25 years, or top 10% in one of my junior partners who, been out of residency for 3 years. So we really look at, what is, what criteria or the criteria we looked at, we could have talked about beginning intern. Are they at the beginning intern level? Now that's still a little bit vague, but I think as we're getting better at it, we're actually defining that a little bit better, and we're finding out ways to make sure that has a sort of a standard understanding about what that means across all the people that fill this out. We also asked for the applicant's most outstanding feature in less than 5 words, which is actually really fun to read. And then the thing that's really been hard to uptake for us is 3 areas of focus that this individual would need to help develop. And nobody wants to fill it out because they think it's some sort of like a scarlet letter, like, well, we all have things to improve upon. We just want to understand, as you're a lifelong learner, what things I need to work on. But that's been a harder one to get done fully. And a lot of people leave it out. And we still have written comments, but we limit to 250 words. And there's some people just want to put their letter into that space, and they can do it, but we realize that most program directors don't look at those written comments. We have a writing guide. So we had a writing guide that was made of learners, program directors, IMGs, osteopathic leadership, a couple of DIOs. And we're really trying to understand, how are you writing this? Are you writing this as an individual? Are you writing it as a group composite evaluation? Is it the chair's letter? How you can represent that so then the reader knows where it's coming from and how it's assessed. What's it based on? Like, when did you work with the students? When they were a 3rd-year student, when they were an acting intern, was it in the lab? Just so once again, we understand, the people that are reading it, the program directors and the program faculty understand where it's coming from. And the writing guide has been a big boon for us, and people have given us really good feedback about it. And we're doing actually some more, I would say rigorous, but we're doing some more surveying to get a sense of where to improve upon this. I think we have some ideas from a lot of basically focus groups that we've done across the country. With the ARM, we have something called the ACI, or the Alignment Check Index, and it's really a tool for applicants to seek what they're looking for in a program, and programs to try to articulate what they're looking for in an applicant. Now, this sounds really simple, but the difficulty thing is that programs are looking for lots of different things, but there are definitely trends of what is important for some programs versus others, or things that we really don't find important or don't value quite as highly. So we have these 6 groupings right here, and we had each program director with a 100-point scale, with 100 points, weight these different ones to see, what do you find more important, or what do you really value? And that really helps applicants do this. And they go to the FRIDA system, which is run by the AMA and AAMC. You put in what you're looking for, and then they'll give you a bunch of programs that might match your desires and needs. So we look at academic metrics, work experience, community service, research experience, teaching experience, and background lived experience, journey traveled, distance traveled rather. And once again, it's a tool that is really for applicants to say, hey, these are programs I never even thought about, because I never realized that they have similar, goals and things that I want in a program. This is just did it for the first time this application cycle, so we haven't evaluated it yet. So we're very curious to see how it was used in the application process. More to come on that. But once again, it's aligning what those metrics are that the programs feel are important, and then try to match up with the applicants and what they're trying to figure out where they want to go. So program signaling, not new to OBGYN. We're a little bit different. Actually, for those who don't know program signaling, it is the opportunity for the applicant at the time of their application to say if they prefer your program based on what they know of your program. They have not interviewed with your program necessarily, or they have not interviewed with your program. They may not know anything other than what you see on their website, but there's ability of them to say, hey, you're a program that I prefer. Many disciplines have done this differently. Some disciplines have as few as 3 signals rather. Orthopedic surgery has 30. OBGYN has 18. We have 3 gold and 5. Actually 3 gold and 15 silver. Sorry, I don't know why I reversed that. And we finally got to see how that affected applications and interviews. We don't have match data yet. We're going to start looking at some match data, and I've heard some, interesting anecdotal because of the match on Friday of what's happened. But what we've learned is actually really fascinating. This is from the AAMC preliminary data. They're letting us share it. But if you are an out-of-state applicant, so this includes your own medical students. Okay, so the graph on the left is in-state applicants, and we know geography matters. But if you're an out-of-state applicant and you do not signal a program, the chance of you getting an interview is 5%. So that is actually very important to realize, because if I'm an applicant, I'm going to use my signals wisely, because you're never going to get into a program you don't interview at. And if you don't signal them, once again, an OBGYN, which has a lot more applicants than there are spaces, it actually does make a difference. So to me, as someone who advises medical students, when you apply, do all your homework on the front end, know which programs you really like, know which programs you may be competitive for, really come up with a good list of programs, realizing that you may get an interview without signaling them, but you probably won't statistically. In-state might be a little bit differently, because a lot of that was, in our first year of rollout, we told students to signal your home programs if you're interested, but most programs said, don't bother signaling, we're going to interview you anyway. So that's to take out some of the background noise. But signaling seems to matter in OB when you have 18 signals. More to come what happened on the match side. But once again, when this shared mental model comes out next year, if I'm an applicant next year, I'm going to signal. If I'm interested in a program, I want to go somewhere, I'm going to be really good with my signals. It may not be for aspirational programs as much as it is for programs you're truly a good match for, but more to come on that. And then lastly, as we kind of run to, kind of go to home and see what questions and what discussions we can have, the next part of this grant for the OB world is really the coaching and readiness. So we're really looking at, some of the knowledge and skills that are necessary for day one of residency. So we do have some self-directed learning. We have this really interesting text-based way of doing questions every day for people who sign up for it. That can lead to good discussion. A lot of group coaching and instruction about growth mindset and resilience. And then really looking at, before you start residency and as you start residency, what kind of one-on-one coaching can you start at the beginning? And it's sort of my aspirational dream, not part of the grant project, but wouldn't it be great if, just like in the GME world, when someone transfers from one residency to another, you have to give them the milestones and a milestones assessment of where they're going? Wouldn't it be great if medical schools did that? And not the letter of evaluation and not the dean's letter, which is the aspirational view of things, but a true assessment of the strengths and weaknesses. So I know day one, hey, you have a lot of great strengths. You have some things you're going to work on. Let's work on those in the beginning. Let's not wait till they show up clinically if we know they already exist. So once again, we're trying to be more proactive, and a lot of this is self-assessment. But if we can figure out areas that we know can improve immediately and do one-on-one coaching, our hope is that that'll help improve that transition to residency. We don't have data on this quite yet, other than some feasibility issues, but I'm excited to hear what's going to come of this over the next couple of years as we kind of wind down this grant and where it goes from there from a sustainability. The problem is the one-on-one coaching is very time intensive, that we already know from our studies, and getting people who are willing to give their time on the faculty side to do that with all the other pressures they have on them is proving a little daunting, but I think it's overcome by the value it might have for the applicant or the then resident doing a whole lot better in their program. More to come on this, but we're excited to see where it goes. And I think this really fits in, I found this slide that Tom Naska gave, back when I was a program director in the mid-2000s. And this is actually not surprising, right? We know that students, and I'll say students, not applicants at this point, in this continuum of practice, different skills will develop differently. And NASCA and the GME recognize this, that you're not going to develop all skills at the same time. And I would say, as a residency program director, when I was a program director, sure as a DIO, I struggle more with the professionalism issues of our applicants and our residents rather than I do with their medical knowledge, right? So, are we really working in the professionalism? Are we really working on systems-based practice and patient care aspects, really fundamental skills? And for me, this really kind of goes down to something I was thinking about when Jed Gonzalo has us in our work groups. And we're talking about, he asked the members of this one work group, what are the really important skills? And the skills that I came up with are humility, reflection, and curiosity, right? Those are things that I find are incredibly successful. And those are the things that are, are we looking for those things? Are we developing those things in people who may, have good humility and good curiosity, maybe not aren't self-reflected? And I started thinking about the skills that we needed. And I was just thinking, wow, if I think about the things that I learned in medical school, many of which are no longer applicable because the science has changed. But if we train people in screening, brief intervention, referral to treatment, yes, I'm an addiction person. That's a skill that's helpful in so many ways that'll cross specialties. If you understand trauma-informed care, that's going to be a really important skill that crosses disciplines. If we talk about motivational interviewing, and how to evaluate the medical literature, which is where I started into education and doing evidence-based practice, and making people systems thinkers or even better system citizens. Those are really things that are going to really, no matter what they go into, it's going to something I believe will affect their entire career. And when I think about system citizenry, and people have heard my talk about this in this group before, system citizenry is an identity. And an identity is based on skill and assessment, but there's a systems thinking skill that we can give medical students that they can then continue to develop as residents and as practicing physicians. Like, that'd be amazing, right? That's really how we change care and how we make things better. And that's the opportunity that we have in medical school education and UME. That's also important in GME, which is also important when you go into practice. And that's a whole nother level of discussion of how we prepare people for practice. Because I have a lot of people right now, people that work in GME right now, your graduates are asking you the craziest questions. My OB residents ask me simple questions in clinic. How do we treat vaginitis again? It's like, this, but they get nervous. Like, they realize I'm going to have greater independence. And that's in a program in OB where we give our chiefs a lot of independence. We understand that, but they still have this doubt. What happens if you're in a program that doesn't do that? Really interesting to think about. So, for me, when I talk about, I'm a systems thinker and I'm proud of it. When I think about systems thinking and workarounds, if we can redesign UME to better meet the needs of what practicing physicians need, and we can really go to competency-based assessments to replace MSPEs and LORs, wouldn't it be great? Here's your competency-based assessment that's continuously getting developed. And when you're applying, here's your update. This is where you're at. Rather than coming up with this artificial letter of recommendation when everyone's amazing. Everybody is amazing, but where are their opportunities? If we had more GME positions, it would be really help. And I think more GME positions in the right areas. And that's why I like being a DIO, because I get to be part of those conversations and figure out what communities need and try to use education as a way to improve the healthcare of communities, which I innately believe is true. And then the things that are workarounds are application caps. You can cap applications. People would argue that 18 signals is effectively going to cap applications, but that's really a workaround. That's as a way to sort of decrease the number of applications because we have another problem in the system. How do we fix that system? And program signaling, I think, is helpful. But one thing, I think it's a workaround. I think, if we're doing a better job of people thinking about which programs they really want to be at, and we get away from you have to get to your top 3 choices, we change culture. I think some of these things that are innovative will probably be deemed workarounds, maybe not so much systems changes, but for now they're actually, application caps. No one has the guts to do. No one wants to restrain a trade lawsuit against them. But program signaling, if the OB data continues to be true, kind of becomes a de facto cap, because you're not getting an interview, you're going to stop applying. So what's on the horizon for those that don't live in the UME, GME world quite as much? Geographic signaling is starting next season. The AAMC feels that, we know geography is the biggest motivator for people and where they go to residency. So they want to have both specialty signaling, like I talked about in OB, but also geographic signaling. More to come on that, is rolling out soon. Most people don't know that it's coming, and we actually don't know how well programs are going to look at it. So it's a double-edged sword. Holistic review of applications will continue, but how to do that best and how do we have to change the application process to get that? Right now, it's supplementary applications. That seems like a workaround to me to change the application. Why make a supplementary application? So lots of discussion in a lot of fields about that. OB, definitely one of those. I would say reevaluating medical school curricula. And I think, right now JED is going through that great process, not just for the UME, GME transition, but looking at what do we need to do to make, the best practicing physician, knowing that's where most of our graduates wind up going. And someone's going to talk about application caps, but once again, they need a really good attorney in employment law and constitutional rights. So with that, I will show you my dog staring at my backyard and why I love living in Roanoke. And definitely any conversations, discussions, or questions, I'm happy to answer, and I will stop sharing as you see Murray. So.
Thank you so much, Dr. Ollendorff. We do have a couple of comments in the chat, and I'll relay those. Dr. Schmidt-Dalton mentioned or filled in some information regarding the learner who went into PMR, and folks can read that comment there. But just in summary, she said that we have an intro to PMR session in the final M2 block in CS as well. So just to provide some additional information there. Dr. Misra mentioned we have to enable a culture of curiosity for our learners. And it also looks like Heather was able to pull up documents pertaining to many of the things that you mentioned in your session.
Yeah, I don't know how to foster curiosity other than, develop the right culture, right? I think that's a lot of its culture, and, being allowed to ask questions. And, I like being challenged. I'm okay with that, probably because I'm where I am in my career. I probably didn't love it quite as much when I was first in practice, but I think that's how curiosity is where all questions can be asked, because you're doing what's best for the patient. And what's best for the patient, it comes down to my favorite definition of evidence-based medicine. It is the best clinical evidence through the experience of the provider that meets the values of the patient. So they're all important. Not one of them is most important. My favorite example, is in OB. You have someone coming into the ER that has a hemoglobin of 3 from bleeding fibroids. They're unstable. Yeah, you give them blood, but they're a Jehovah's Witness. They refuse blood. Okay, what's plan B? Once again, that's the curiosity. What else can we be doing? What else meets their values? What else can we be doing? We're not saying, oh, we're done here, we're moving on. No, we're going to take care of this woman. So yeah, that curiosity, I think, is a culture. And when you have it and how do you create it? I am not an expert in that, but I think that's where we want to get, for sure.
I think we are doing that. I think we are enabling our learners to ask questions, and we're enabling our learners to question our practices, including all the systems that are in place. I think what's important is sometimes we hear the same questions over and over again, and you go, okay, we've dealt with this. And that culture that we have to build has to start with us. We have to encourage people to question whether this is the right thing, whether the system is acting right. And so that's what I liked about all the research that's going on, especially in the OB-GYN program. I mean, it's actually very, not only heartwarming, but also inspiring. And we need to make that culture available to all of medicine, not just particular aspects of it.
No, thanks for that feedback. Yeah, I think, we've reflected, like, why has OB/GYN been able to do it? I think we're like the perfect size. We have about 270 programs, about 1,500 residents a year. There's lots of goodwill built up between the UME, the GME side, the two, APCO, which is the UME arm of our education side, and CREOG, the GME. There's a lot of overlap, and we've always recognized that. And, I think we're able to impact it differently. I think that's why smaller programs have been able to do that, or smaller disciplines have been able to do that. Internal medicine, it's really difficult, right? I mean, it's such a large number of people, large number of programs. Not that it can't be done, but I think it's a little bit different, the approach they're going to take on the implementation arm, if they want to go this way, or general surgery, or some other of the larger disciplines. But yeah, and I think we feel in OB we were fortunate because we kind of had the right environment. And there's a lot of trust in the field. Everyone felt we're doing this for a reason that was important.
I think maybe Dr. Sweet might have had a comment or a question a moment ago.
I will come off mute only to say, no, I was just on video.
I was going to say, which Dr. Sweet? Maybe your wife.
This is true. That was rather presumptuous of me.
No, I don't even know she's on the call, but.
No worries. I thought I saw you come off mute, so wanted to make sure you got your opportunity to make a comment or ask a question. If you do have a question, please feel free to unmute yourself and ask your question, or raise your hand if you're not able to unmute yourself at the moment. Go ahead. Sorry, Margaret.
That was so incredible. I am so inspired by your field, and what a joy. You mentioned a system where the students can go online and do this assessment, ACI. I didn't catch the name of that. You said it was available.
Someone was really great and put it in the chat. So it's through Frida, which is
Frida. Oh, I see that. Okay,
yeah,
sorry.
so yeah, just go to that
That's
link. So helpful. Yeah, you may not be able to access it as you might be able to. I've never tried to, but you can kind of see what it's all about. And someone else actually put a link to the RRR website, which is where we kind of house all our information through apco.org. And and it says RRR grant on the,
So it's only
page.
for OB/GYN residents.
it's only for OB/GYN residents right now.
Cool.
So I'd like to just echo Dr. Extal's comment that this was a fabulous presentation. However, I'm the dean and I write dean's letters, so you might not believe me because, you know, everyone is better than they appear. But no, I'm just seriously, Arthur. I just want everyone to know that we're so fortunate to have, you know, two national leaders at the cutting edge of this UME GME transition with Drs. Ollendorff and Gonzalo. So we don't have to just watch it. You know, we can hear about all of these innovations happening as they happen and become part of this process of improving this transition. So I just wanted to just mention how fortunate we are. And although I'd heard pieces of this before, I always learned something when I listened to Dr. Ollendorff. It was a pleasure to be with you today. Thanks.
Thanks, Dean Lehrman. I always think about things a little bit differently the more I talk about it. Or trying to explain this to my father, who's an attorney, is actually fascinating. Try to explain the process of the match to a non-physician. They think you're crazy, and maybe we are a little bit. But you know, I would say law school is no better. My daughter is a third-year law student. It's all about your LSAT score. It's your LSAT score and where you went to school. There's no holistic review of anything when it comes to law school. So we are ahead of our attorneys. Right. Hearing nothing, I'm looking at Sarah, who can't tell I'm looking at her because it's Zoom.
Yeah, so just one more thing. It looks like Dean Lehrman did add a comment that I'll go ahead and let folks know about. He said, for those who are curious about how well Virginia retains medical students and residents who train in Virginia, here are data published in 2020 by the Virginia Healthcare Workforce Advisory Council of VHHA. UME only in Virginia at 32.5% practice in Virginia. GME only in Virginia, 39.1% practice in Virginia. Both UME and GME combined in Virginia, 64.3% practice in Virginia. Thank you, Dean Lehrman, for sharing that data with us.
Yeah, I mean, yeah, that's really good data to have. The only other data that we have is over the last 2-3 years, we're retaining about 22 to 23% of our resident graduates in Carillion practices, roughly about 40% in the state of in the Commonwealth of Virginia, and kind of like a number in between there in Southwest Virginia, not necessarily with a Carillion practice, but another practice in the region. And I think those are data points I'm used to looking at, you know, especially my other job when I work for an AHEC, where like, hey, how many people how are you retaining? And historically in MAHEC in Asheville, we were retaining 60% of our graduates in the region. Which was, and I think that's going to start changing as Asheville gets bigger and more crowded. But you know, it can work, especially in the early setting as you're looking at the healthcare workforce.
All right, if anyone else has any questions or comments, please ask those at this time or add them to the chat.
Dr. Vitt has a question.
Yes.
Hey, Arthur. Hold on to your chair. Arthur, so provocative question. I don't know the answer to the particular question. You know, are we training medical students to match? Or are we training medical students to be residents? And I wonder if we shift the needle here, if we get to a point where we can divorce medical schools from the outcome of the match. If you have two entities that are both in this for the same reason, i.e. the medical student wants to match, and B, obviously there's some visuals for medical schools here around the match and where do my people go? And you know, we have match day that everybody celebrates, and we create slides about look where our students went and the like. Until we divorce those, I wonder if we continue to train medical students to match as opposed to train a medical student to be a resident. And I wonder how much we shift the needle when a lot of what we do is predicated on the outcome of this particular event. And we rather look for a different surrogate marker of what equals success for a medical school. Do you see what I mean?
Yeah, I mean, I think, you know, I would say the vast majority of the time they're probably aligned, right? Where the student wants to match is, you know, probably fits well. I think it becomes more interesting when, you know, actually I'll use my wife as an example. And, you know, my wife was AOA, you know, top of the medical school class, I think super brilliant. And she was going to family medicine, and the chair of medicine pulled her aside, like, you should do med peds. Why? Because it's med peds. Because it was at that point, this is the 90s, where family medicine wasn't as respected as I think it is now. You know, to him, that was a metric. Like, I can't have a top student going to family medicine. Why not? Like, that's a good thing. So I think we have to change our expectations. But once again, I think, yes, you know, our students are very high achievers. They've been very good at achieving things because that's how they got here. And I mean, and like I said, I think most of the time it's aligned. You know, I think, you know, I can talk about the 6 students going to OB. I think they all matched the programs they really wanted to go to. I'm really proud of the programs they went to. I think it worked out really well. There are times where it does conflict, right? And there are times where, you know, especially in your ultra competitive, you know, residencies, that happens. But I think it's also not time for the residency programs to understand what's going on. I mean, I have conversations all the time with the unmatched student, actually, that from another school. I should do a research here. I'm like, is that gonna make you a better OBGYN? Like, you know, what do you need to work on? It's like probably my clinical side. I'm like, so do a prelim year. That's what she's doing, right? So I think it could be both, but I think it, you know, I think the holistic review will really help us understand what we really want. And it's not going to be, I had a 270 on my step 2. Yeah, you got a 230. That's important. You're smart enough. Do you have these other qualities? What really drives it? And once again, it's always going to be competitive. And I think you're right. I don't have an answer either, Mike, but I think it's a good question to ask.
It's really a great question, Mike. I do appreciate it too. And I look at it this way. We bring value. There are a number of different perspectives on different sets of outcomes. So you may be happy to hear that although we have all of the hoopla that every other school has with respect to match day, that it's not on our strategic planning metrics at all. The things that are on the metrics are how many stay at Carilion Clinic, how many stay in Virginia, how we help provide graduates that reflect the populations that receive care from them. Those are the things. So we don't feel any tension between those. It's just for us a question of the different stakeholders, the outcomes that matter to them at different times. And but you're raising an important point, because if we're teaching to the test, let's back it up a bit, you know, teaching to the step 1, which has become step 2, or teaching to the match outcome, you know, that's not what any medical school should be trying to do, even though they may celebrate their successes. So thank you for bringing that up.
Yeah, I'm in a very fortunate position. I find myself in a fortunate position because, and this is clearly not pointing fingers at any one medical school. You know, we get about 3,000 applications to residency, and so we get a wide look at the way different medical schools, you know, approach things and application packets. And golly, after you've been through a number of these packets, you realize it's rinse and repeat. And if you look at what we're putting on there as being important, you know, that's not always important. It doesn't speak to that holistic review. And obviously, every student is the best student you've ever worked with. But yet, when you look at the objective data, I suspect you're not the best student you've ever worked with. But that's a different discussion. It just seems like we're fixated on, not fixated. An important component of this is the match, which clearly is important. And I'm with Arthur on this one. Whether you match with your first or your 10th, if you're in a place that you're happy, that should be good. And that would take away some of this tension that's built up in this match packet that is all about the best, and you will end up at this institution, which I think puts more pressure on the students.
There's something I call, Michael, you'll enjoy this, I hope, the illusion of the single best choice. Something I made up. And you could fill in the blank. It applies to, okay, let's back up. It applies to health careers. It applies to specialties within medicine. It applies to programs for residency training. It may even apply to areas of practice where you'd like to practice. The illusion that there is a best choice, instead of there being a range of outstanding choices and we struggle to get past a random decision. I think it's really hard.
That's a good way to end it. I think it's really hard. So I agree with Dean Learman.
Yes, thank you everyone for your wonderful comments. Dr. Ollendorff for a fantastic presentation. It was spectacular. We look forward to seeing you all next time. If there's anything we can do to support your learning needs, please reach out to our team. We'll be more than happy to assist and support you. Everyone have a great day.
Thanks, everybody.